We are all very grateful, Dr. Galvin, for your giving us your time and expertise in this area of work. And so I'd like to introduce James Galvin, MD, MPH, a board certified in psychiatry and neurology, professor of neurology, chief of division of cognitive neurology, director of the Comprehensive Center for Brain Health, and director of the Lewy Body Dementia Research Center of Excellence. Dr. Galvin got his MD from Rutgers University and a master's in nutrition, also from Rutgers. Was the chief resident in neurology at Hahnemann University, and did a postdoctoral fellowship in neurodegenerative disease at the University of Pennsylvania. Dr. Galvin has authored over 370 scientific publications and 3 textbooks on healthy brain aging, cognitive health, Alzheimer's disease, Lewy body dementia, and related disorders. He's received over $125 million in research funding from the NIH and other disease associations, as well as private and family foundations. Dr. Galvin directs the Comprehensive Center for Brain Health, the CCBH, to study brain health and risk of neurodegenerative diseases such as mild cognitive impairment, Alzheimer's disease, Parkinson's disease, Lewy body dementia, frontotemporal degeneration, vascular cognitive impairment, and chronic traumatic encephalopathy. The CCBH also uses transdisciplinary approaches for research and clinical care, combining the best practices of neurology, gerontology, cognitive neurosciences, nursing, social work, psychotherapy, integrative nutrition, mindfulness, lifestyle modification, physical therapy, public health, medical education, epidemiology, biochemistry, genetics, data science, and biostatistics. And so without further ado, I am very honored to introduce you to Dr. James Galvin.
Well, thank you, Laura. I'm delighted to be here. Welcome, everybody. So what I thought I would do today is talk a little bit about our approaches to applying precision medicine principles to enhance our studies of brain health and the risk of Alzheimer's disease, hence my title. And so what I thought I would start with is sort of going through some of our research and our findings, and then end up on how we're trying to apply this in real-world clinical care. So here's my disclosures. Let's see. All right. So real quick, what the Comprehensive Center for Brain Health is, it really is trying to take a comprehensive and customized focus on prevention and health rather than disease. Trying to understand how the aging brain works, and then we can design treatment and prevention plans that will result in longer, better lives. So our group does research, clinical care, outreach, education, and training. Our vision is to try to apply all of this to address healthy brain aging and neurodegenerative disease. And obviously our long-term goal is to try to translate these findings into new models of care. This is our team. It's actually a little bigger now. And our vision statement is to build a better brain, build a better you. And so here's our NIH funding. I like showing this figure. So I used to have a slide with listed all my collaborations, but as they got bigger and bigger and bigger, the print got smaller and smaller. And so we went into this, became interested in some of the social networking software. And so this is my social network of my research collaborations. And so with us in the center, these are my collaborators that do mostly brain health and Alzheimer research. And here's my collaborators who do Lewy body research. It's a much smaller group, and so it's more tightly bound, but I always like the shape of it. It's kind of cool. So, what is precision medicine? So basically, this is just simply a model that helps us separate people into different groups. It can inform medical decisions, practices, treatments, and that we can tailor to subgroups of people based on their predicted response or their risk of disease. This is commonly used in cancer. It's genome-based, and so all the genetic information, the genotype of someone, is obtained through the biopsy of the tumor. You look for markers, and then you design the therapy based on those markers. Of course, we can't take a piece of the brain. So instead, our approach is that we phenotype individuals. So we look for little deviations from normal or expected structure, function, or behavior. By doing this, then we can get a very detailed picture that characterize the factors that make a person either more likely to develop disease, progress faster, or have poorer responses to treatment. So we're going to call that vulnerability, or make them less likely to develop disease, progress slower, and have a better response to treatment. So we're going to call that resilience. And there's real benefits to this, both from a research and a clinical perspective. We can shift from the concept of reaction to prevention. We can potentially predict susceptibility, improve detection, maybe halt progression. We can prescribe more effective drugs. We can avoid drugs with side effects. And ultimately, we eliminate trial and error. So how does that apply to the things we're interested in? Well, Alzheimer's disease itself is really a very heterogeneous disease, right? There are, close to 7 million Americans and 55 million people worldwide who live with the disease. And age is the single greatest risk factor. So at age 85, there's roughly a 40% chance of having a dementia of some form. And if you belong to a racial, ethnic, social, economic, or geographic minority group, you have somewhere between a 1.5 to 2-fold increased risk of disease. But as we take care of people, there are some people who develop disease, but others do not. And I'd like to answer the next question is why. Some people we treat progress faster than others, and the question would be why. And some people respond to medications while others do not. And again, why? So we became more and more interested in this concept of why. And we believe that if we can understand the why part, this can help us improve treatment outcomes. So are there things that make people more resilient or more vulnerable or more responsive to therapy? So I'm not going to talk about the pharmacological approaches in this talk, other than just very briefly overview them. So this is a nice slide that sort of gives you the entire anti-amyloid therapy timeline. So, back in the 90s, we had the symptomatic medicines, first Aricept, and then the other cholinesterase inhibitors, followed by Namenda. But around 2006 really was the first sort of anti-amyloid approach, and that was with an active vaccine, AN1792. It had a lot of safety concerns, so it never made it any farther. And then the monoclonal antibodies started being used, and they really had no obvious clinical effect, and they really had limited amyloid reduction. But from July 2018 on, really came the new phase of the approach. And these antibodies were designed a little bit better, and they had a greater potential to hit target. And so ultimately, these phase 1, phase 2, and phase 3 studies led to the approval of aducanumab with an accelerated approval in 2021, although it's now been discontinued from the market. And then again, going along the path, in July 2023, we had lecanemab's traditional approval, and then donanemab is under review. Their PDUFA date came already, but the FDA called an advisory board. So we're still waiting to hear from this. But both phase 3 studies for lecanemab and donanemab showed a clinical benefit. And that's important. But hidden within all those facts, there's some really interesting things. And that would be, in both antibodies, people with low tau really were the best responders. And particularly in the donanemab study, people with high tau actually had no response to the medication. So studying amyloid by itself doesn't really tell us much about what's going on in the people's response to treatment. So it'd be important to find out more about what might predict a response to treatment. So what's really interesting, though, in the clinical trials, and I'm coming to the end of sort of the clinical trial part of this talk, is that for different reasons, for aducanumab, donanemab, and lecanemab, there were breaks in therapy. And those breaks in therapy were for about 1.5 years. And so what was interesting was that during that break from the end of their double-blind placebo-controlled study to either an open label extension or a recontinuation of therapy, what we saw for all three compounds was a slow increase in the redepositing of amyloid, and in particular, A beta 42, which is the more toxic species. So even though it was very effective at reducing it, once you stop the therapy, amyloid starts to accumulate again, and the patients start to worsen again. Now, there is a clear sort of disease modifying effect. That is, they decline very similar to the prior placebo group. But the fact is that they do get worse. So even though the amyloids are below the threshold, they are now getting worse again. So again, this idea that there might be, other ways of approaching the disease, and that again, that's going to be largely the focus. And my interest is really in prevention. Now, from a last drug slide, from a drug perspective, there are prevention studies undergoing. So there's the AHEAD 3-45 study, which is using lecanemab, and the Trailblazer-ALZ 3 study, which is using donanemab. But if you look, enrollment in 3-45 is based on the amount of amyloid in the brain, and enrollment in ALZ 3 is based on the amount of phosphorylated tau in the brain. So really, they're trying to cherry pick individuals based on how much Alzheimer's disease pathology. So you have to have enough pathology to be in the study, and you can't have too much pathology to be in the study. The question is, how are we going to apply that in real world settings? I think that's going to be the real challenge here. So let's focus on now a different side of the story for the rest of our conversation here. So again, very interested in dementia prevention, and want to think about this as how could we do this, right? Concept is great, but how do we actually do it? So it's always nice to have some models, and they kind of let you think about how you would approach the problem. So this is from a paper we published a couple of years ago. And basically, as cognitive function declines, age increases. And so you can see, there are individuals who have, no evidence of disease. Those would be the people who have primary prevention strategies. That is, you're preventing the onset of disease before there's any disease or injury present. So you're going to reduce the incidence. And so these are people that have no cognitive impairment, or people who have subjective cognitive impairment. Then there are people who develop Alzheimer's disease changes in the brain, but they don't have symptoms, or they have very, very, very mild symptoms. And this would be the group that you're doing secondary prevention on. That is, you're going to reduce the impact of a disease or injury that's already occurred, or reduce the prevalence. And this would be people who have preclinical Alzheimer's, right? That is, they have Alzheimer pathology but no symptoms, or people who have the very earliest signs of mild cognitive impairment. And then the group that often shows up in our office is the tertiary prevention group, and that is the people who already have MCI and or clinical Alzheimer's disease or related disorders. And this is tertiary. That is, that you already have established disease, so you want to try to arrest the progress of the disease and control some of the negative consequences. And so the best you can do is reduce disability. Okay. So we wanted to think about how we could potentially apply this in life. So this is from a study, I always say a few years ago, but as I get older and older, I realized that I published a study longer and longer ago. So this was from 2009. So this is when I was at WashU. We had a longitudinal study that had been going on for 25 years. And so we looked at our cases of people who are healthy controls, and then a subset of people who have clinical Alzheimer's disease, and a group of those who developed autopsy data. And while the overall cohort is much, much bigger, these are the people who had all of the variables we were considering for this particular study. And so what you can see is, if you look at the controls over time, they have very little decline in their cognitive ability. But the people who started out as controls and eventually develop Alzheimer's disease, they show a decline. And so at this dotted line right here is where we make the diagnosis of having Alzheimer's disease. But the other thing you can potentially see is that about 2 years prior to getting a diagnosis, there's an inflection point in their cognitive performance. So they start to show some decline. They're still scoring in the normal range, but they're different than they used to be. And so we can start to think about, now we have this inflection point break period. And so this is really the first way retrospectively we can go back and say, these people have preclinical Alzheimer's disease. So if you remember from the other slide, we had the red, yellow, and green kind of color coding. So if we color code this chart now, what we see is that from whatever time up until this inflection point, these are people who do not have any evidence of disease. This is our primary prevention group. During this preclinical phase, this is our secondary prevention group. And then after they have a diagnosis, this is our tertiary prevention group, okay? So how do we do this in clinical practice then? Well, let's think about the clinical expression. When someone shows up in the office and we make a diagnosis of Alzheimer's disease, but prior to that, maybe 2 years, 3 years, they started having some cognitive change, some decline. And prior to that, they were having some changes in their brain. So they had some neuronal injury followed by neurodegeneration. And that might be 5 to 7 years before they show up in the office. And before that, they're developing plaques and tangles. And this begins maybe 20 years before they have a clinical diagnosis. And if you have plaques and tangles, there are things that probably increase your risk of having plaques and tangles. So let's call that risk factor A. But from autopsy studies, we know that most people just don't have plaques and tangles. They have lots of other things. They have other pathologies. And if you have other pathologies, in theory, they should have other risk factors. So let's call that risk factor B. So if you wanted to try to treat or prevent Alzheimer's, well, you could address the Alzheimer's pathology, the plaques and the tangles, and that's what the pharmacology, the pharmaceutical industry is doing, right? So I'm going to leave that behind, but I'm really interested is that maybe there are multiple ways to get to Alzheimer's disease, and so we could address maybe these other pathologies and mechanisms. So neuronal injury, inflammation, vascular changes, synuclein deposition, et cetera. And again, keeping our concept is that if we address these risk factors, we're in the primary prevention phase. If we're addressing sort of some of the pathology before they're overtly having cognitive decline, that puts us in the secondary prevention phase. And then once they have some symptoms, that's in the tertiary prevention stage. Okay, so with that as a backdrop in our models, let's talk about some of our research. So we're really interested in this concept of resilience and vulnerability. And there was a large work group that occurred last year led by Jakob Stern from Columbia University. And so there's lots of terms that have been thrown out in the literature and people use them a little bit differently. So when someone's talking about cognitive reserve, it may not be the same thing that someone else is talking about. So what they tried to do is to come up with some common definitions. And so these concepts of cognitive reserve, brain maintenance, with a useful definition, we can all be on the same playing field. So brain maintenance is thinking about those protective lifestyle factors, healthy diet, exercise, that may lead to better brain health. That is, they have less atrophy with aging and thereby having better cognitive function. And this is very distinct from the term cognitive reserve, which refers to some active and dynamic process that maintains cognitive function even in the presence of brain pathology like Alzheimer's disease, until there's so much pathology that a threshold is met and people become symptomatic. So now we have standardized different definitions, but again, the question is, how do we operationalize this? So how do you apply this in a sense that you can tell whether someone has cognitive reserve or resilience? So again, we started thinking about this a lot, and we know there are genetic mutations. They're very rare. They lead to rare forms of familial Alzheimer's disease, but it's very hard to explain the much more common sporadic case. So why are some people more resilient or vulnerable than others? And there's no single risk factor that can explain that. Rather, it's probably a combination of a whole bunch of interactions of genes, environment, lifestyle, exposures, comorbidities. And so the way I like to think about it is good resilience can offer protection from a bad environment, and bad vulnerability can be buffered by a good environment. So there are things that we can do to build a better brain. And again, the challenge has been, how do you measure these constructs? And so I like to jokingly say, this is how we spent our pandemic. Because we were home, we had a big data set, we couldn't see people, so we really, dove into our data set. And so the first thing we did was tackle this concept of resilience. And so we looked at all our data that we had been collecting. And one of the things I do in my research is I try to create scales that allow us to capture and understand phenomenon, particularly where there isn't a good scale available. So we thought about this, and we sort of combined this concept of cognitive reserve, and we created a scale that allows us to measure that. We created a scale that allows us to look at physical activity, combining intensity, frequency, and duration to estimate a dose. We did the same thing for cognitive and leisure activities across 15 categories where we could calculate a dose. And then we took some other concepts, mindfulness, diet and nutritional patterns, and social engagement. And we combine these all together to then create what we call the resilience index. And so it's a summed factor of these different components. And so here's our resilience scores here. First, just look at the distribution, which is really nice, is in our cohort, it's a nice normal distribution. The mean, median, and mode are the same. So again, really performs nicely. It has minimal floor and ceiling effects. No one gets a 0. No one gets the highest score, right? So, most of the people are in the realm of the 95th percentile, and then the tails have few people that are in them. So what we found was that controls have higher resilience than MCI. MCI is higher resilience than dementia. That's probably not surprising to you. But what was interesting was within groups, controls that had high resilience had better cognitive function, better behavior, better everyday activity performance than controls that had low resilience. And this was true also in the MCI and the dementia group. So even though they were controls, those people who had higher resilience had better performance on their cognitive test. Then we had tackled this concept of vulnerability. And so what makes someone at higher risk for development? Are there things that we can measure? And there's a whole bunch of different ways of looking at this, but we took all our data, we used some machine learning modeling, and we identified 12 factors, both modifiable and non-modifiable, that were most strongly associated with the risk of developing a cognitive impairment. So this included age, your biologic sex, race and ethnicity, and your educational attainment, vascular comorbidities, obesity, frailty, and depression, and we applied a weighted score. So we created this vulnerability index, and again, we get a nice normal distribution. The median, mode, and mean are about the same. So we applied weights to these because they are factors that are present. So we want to know how much they may individually be contributing risk. And what we found was controls had lower vulnerability than MCI, who had lower vulnerability than dementia. And within groups, controls who had lower vulnerability had better cognitive, functional, behavioral outcomes than controls who had high vulnerability. And this was also true in the MCI group. However, it was no longer true in the dementia group. So once you crossed the threshold and developed a dementia, vulnerability played less of a role in your progression. You were maximally vulnerable. So the tools have really nice psychometric properties. They're easy to collect. It's a brief survey. It takes about 7 to 10 minutes to complete. And so we get nice areas under the curve. We get good cutoffs that give us good sensitivity and reasonable specificity, but we get great odds ratios, right? So we have really good diagnostic odds ratios. So we can correctly identify people who are cognitively normal and correctly identify people who are cognitively impaired just based on their resilience and vulnerability scores. But they only measure risk. We actually wanted to also incorporate some sense of how people perform because we care about that. Most brief tests are really heavily focused on memory, and they don't do a great job of measuring that either, but they're mostly focused on memory. However, memory is not always the first domain impaired. In Alzheimer's disease, it is often not the memory domain, not the domain that's first impaired in other forms of cognitive impairment. Whereas attention, executive function is very early changing in people who have almost any form of brain disease. An executive function really is a broad category. It looks at attention, inhibitory control, working memory, set switching, planning, decision-making, problem solving. So we created a tool called the number symbol coding test that allows us to capture exactly that. So you may be familiar with other neuropsychological tests, such as digit symbol substitution. Well, this is a twist on that that adds set switching, right? So first they have to practice going from number to symbol, then they have to go from symbol to number, and then they start to test. And so the first 16 positions are going number to symbol, and then the set switching starts. And once that starts, people who have any form of impairment start to slow down. And so they have difficulty sort of planning and carrying out the activity and switching back and forth between number to symbol or symbol to number. And again, we get a fairly good normal distribution of testing. And so we have people scoring a wide range of scores. No one's ever scored a perfect score. And a few people actually score 0, the very severely impaired people. But most people can give a pretty good effort and we get a reasonably good score. So now that we have a tool that measures resilience, a tool that measures vulnerability, and a tool that measures cognitive performance, what we did next was we combined all these to create what we call the brain health platform, right? And so this allowed us to really do some modeling. And so we created 2 types of models, a diagnosis-based model and a risk-based model. The diagnosis-based model is something like a neurologist would really like. Is this a control or MCI or a person who has a form of Alzheimer's or related disorders? A risk-based model would be more than something we can use in medicine clinics or in epidemiologic work. So are you at low risk or high risk? And what we found is if you had abnormal scores in all 3, you were 96% likely to be cognitively impaired at gold standard. If you had normal scores and everything, you only had a 9.7% risk of being impaired. If both your vulnerability and resilience were abnormal, but your number symbol coding was normal, you were more likely to have MCI. And if all 3 were abnormal, you're more likely to have a diagnosis of Alzheimer's disease. So these models came very much in help. So we started figuring out, well, how can we apply these things? And so we did this study, and this is a sample in New York of about 450 people. And we explored some of the reasons for the differential risk of impairment using this vulnerability index. And so Dr. Kleiman, who I'll talk about in a little bit, is a data scientist. And so he took the Henderson-Hasselbalch equation. If you remember that from your biochemistry classes, it looks at enzymatic effects and how enzymes may catalyze a reaction. And so we applied vulnerability as the catalyst. And we wanted to look at the relationship in cognitive performance potentially being catalyzed by vulnerability. And what we found was that in non-white participants compared to white participants, there was a significant acceleration in the cognitive decline as people became more vulnerable. Okay, so it had its greatest effects in the earliest stages of impairment by pushing those individuals who had more vulnerability, particularly their vascular vulnerabilities, toward becoming cognitively impaired. However, when we considered people's socioeconomic status, those vascular comorbidities plays a less prominent role, suggesting that resources and access to care may be driving the risk that we see in underrepresented minoritized populations. So since I joined University of Miami back in January 1st, 2000, right before the pandemic, again, that's why we got to spend so much time looking at our data. We created what we call the Healthy Brain Initiative, which is our longitudinal study. We just crossed the 300 mark. We collect lots and lots and lots and lots of data that allows us to really deeply phenotype individuals. We're recruiting people who don't have dementia. So we have people who have no cognitive impairment, people with subjective cognitive impairment, and people with mild cognitive impairment. So that's our target audience. And we're seeking out diversity. Our goal is to be at 40% minoritized groups. Right now, we're at 29%. So we're getting toward our target goal. So let me show you some of the data that we've collected. This is Deidre O'Shea, who's a neuropsychologist at our center, and she looked at our resilience index and its relationship to both cognitive performance and cortical atrophy. And what she found was that after doing appropriate adjustments for age and sex, resilience was significantly associated both with less cortical atrophy and better cognitive performance. And she further found that resilience's effect on cognitive performance was partially mediated by its effects on cortical atrophy, okay? So this would suggest that the higher resilience actually protects your brain, you have less atrophy, and this is going to lead to better cognitive performance. This is Lila Besser, who is a urban planner and epidemiologist in our group. And she's been very interested in sort of the social and structural determinants of health. So she used our sample to look at neighborhood green space, interpersonal discrimination, area deprivation, which gives you some idea of the socioeconomic status of the community, our resilience and vulnerability indexes, and our biomarkers. And what she found that if you had more exposure to green space, you had higher resilience scores. If you experienced more discrimination and lived in a poorer neighborhood, you had higher vulnerability scores, and that greater discrimination was associated with more white matter changes in your brain. So this would suggest that individual and neighborhood level social determinants can affect both vulnerability and resilience, setting up the risk for developing Alzheimer's disease. One of the other things we're really interested in is trying to come up with interesting markers. And so these neurobehavioral markers, which really look at non-intentional, incidental behaviors. So when you're directly examining one thing, there are other things that people do as part of those behaviors that we can also measure. So if we're looking at memory, like how similar their responses are, where are they looking? Same thing with eye gaze. For language, we can look at their word choices, complexity, diversity, pauses, and all those other things. So let me give you an example. So we give someone a task on a computer screen. We tell them to count the animals. And that they're looking at the screen and there's an eye tracker on it so we can look and see where their eyes are going, and we can measure all of that. And so here there's zebras, and we want people to count the zebras. But people naturally will look at the rest of the landscape, and so they'll do the task and they'll do some exploration. So we can look at those patterns of exploration. And then we give them the next task, which is we put two pictures on top of each other. So one is the picture they previously saw, and now is a novel picture, and we tell them to count the animals. And so a person who's a healthy control will spend most of their time looking at the novel picture, whereas the person who has Alzheimer's disease will spend about equal time between the previous picture and the novel picture. We can also look at language. So this is the cookie theft story. We could have people look at the story, tell us the story, we record their speech, and we use some natural language processing to look at the context and contents of their language. So how would we apply this? This is Dr. Kleiman, who I mentioned before, who's a data scientist and experimental psychologist in our group. And so he took two of our participants, well, many of our participants, here's two exemplars. So they're both female, they're both 65 years old, they're both non-Hispanic white, they have the same education and essentially the same cognitive performance. Gave them both the eye tracker test and the language test. And what he found was on the eye tracking test, participant A spent 5 times more effort in the novel picture compared to the previous picture, whereas participant B spent only 2 times more on the novel picture. When we looked at their language, participant A had greater diversity and complexity and a higher rate of speech. Participant B had more pronouns to nouns and had decreased word frequency. And when we look back, unblinding to see what their biomarker status was, participant A had normal amyloid and tau levels. Participant B had low A beta and elevated p-tau, which are markers of Alzheimer's disease. So participant A is a healthy control or a true control. Participant B is someone who probably has preclinical Alzheimer's disease. And so we're able to pick that up solely from speech and eye movements. Some other things we've done is looking at gait, particularly dual tasking. And so this is a study we did and looked at our participants walking on a computerized gait mat, The investigators were blinded to their their diagnoses, and so we used machine learning, and solely based on their gait features, we were able to almost perfectly classify them as being healthy controls, MCI or ADRD, just from their gait. So very, very powerful. Our most recent work has really been looking at this concept of curve walking. Curve walking requires much greater cognitive and motor demands. So we can use a kinetic camera and basically create 3D models of individuals while they're walking either in a straight line or walking in a curve. We capture all the components of this. And so what we found was that straight walking had a very difficult time picking out people who had MCI compared to curved walking. So curved walking was a superior way of really looking at this. And so basically, as you'd have someone start as they're walking, particularly as they get into the turn, they start to slow down and have some changes in their gait metrics. And we can use things like step velocity and double support time that can really segregate the healthy controls from MCI. Okay. So as we've been moving on now, we're trying to think about how we can apply this in a real fashion. So I mentioned we collect the resilience and vulnerability indexes, look at brain wellness and risk of disease and their performance from the number symbol test. And we created that brain health platform, which is a great, pretty model, but very hard to apply because we needed to come up with a score. So we used a machine learning model to actually create an index, and it ranges from 0 to 100, with higher scores being better. It allows us to plot each person in the same space, and we can look at cross-sectional moments. What is someone's brain health at that moment? And we can track their brain health longitudinally. So you can see, from zero down here to 100. So yellow in the picture is healthier than purple, which is not healthy. I don't know if you can appreciate it, but there are diamonds. These are the healthy controls, and circles. These are the people who have diagnosed cognitive impairment after our evaluation. There's about 750 people in this sample. And so you can see this gradation. So our healthiest person up here is unlikely to ever develop cognitive impairment. We're following them, but they're unlikely to ever do it. Our least healthy person down here has Alzheimer's disease and will likely progress. But inside the group, you can see there are diamonds that are starting to turn a little purplish. There are also some circles that look a little yellowish. This would say that the controls here are very likely to develop MCI in the next couple of years, whereas these MCI are very likely to progress much, much slower. So we can actually test these hypotheses going forward, now using these indices of brain health. And what we did, we sort of measured it against biomarkers. We're really measuring brain health. This is not a marker of Alzheimer's disease. This is measuring brain health. So our vulnerability is not related to, in any great sense, to amyloid, but it is related to NFL, which is looking at neuronal injury, GFAP, which is looking at neuroinflammation, hippocampal volume, medial temporal lobe volume, how much white matter disease there is, and how much cortical atrophy there is. Our RI is really looking at cortical atrophy. It's not really looking at these injury markers. And our number symbol measures many of the same things that the VI measures. So we really can focus on how someone's brain health is changing. And this allows us to study a whole bunch of different things. So we can look at differences between African Americans and whites. We could look at differences between rural and urban populations. So in a study of rural living African Americans, you can see the same type of pattern. So the people who have no impairment, the people who have possible impairment, and the people who have probable cognitive impairment. And we have ongoing studies in American Indians on 2 different reservations, in Hawaii in a clinical trial, and a prevalent study in American Samoa in the South Pacific. So when we start thinking about our sample, and this is our Healthy Brain Initiative sample, there's about 200 people or so in this plot. And what we can see is if we plot their A beta versus their p-tau ratios, remember, low A beta is abnormal and high p-tau is abnormal. So you can see there are people who are mostly looking like they have healthy brains. So if they do have cognitive impairment, it's very unlikely to be due to Alzheimer's disease. And then you can see people who have low amyloid, which would suggest they're developing Alzheimer's disease. You can also see some people who have high tau, which means they have some neurodegenerative process going. And so it allows us to do some interesting hypothesis testing, because this pattern is the way we think about Alzheimer's disease developing. You develop amyloid, deposit it, and then later on you deposit tau. And then you develop clinical symptoms. But we have a smaller number of individuals who aren't following that road. They're taking their own path, right? And so they're developing what looks like tau first and then depositing amyloid. So we're going to be able to really test this. So we have different groups of at-risk individuals based on their biomarkers. And we have lots of other markers, as I mentioned. So we're now looking at the genomics, epigenomics, proteomics, biologic clocks, the inflammasome. That's going to really sort of get mechanistically what's happening to these individuals. So I want to show you something really cool. So you have to wait 5 years to get 5 years of longitudinal data. But there's this model called SUSTAIN, which is a subtype and staging inference algorithm, was developed at University College in London, but really a powerful tool for looking at potential progression of diseases, but you can use cross-sectional data to do it, right? So it really allows us to visualize what's happening. And so they use data from the Alzheimer's Disease Neuroimaging Initiative, so their MRI, and compared it to their CDR stages, clinical dementia rating stages, and they came up with all these different metrics. So it was a really interesting model. So we said, well, can we apply this to our data? Because we're really richly and deeply phenotyped. So this is work from Dr. Mirza Beg, who's a postdoc in my lab. And so he applied this, and we came up with 3 subtypes. So our groups broke into 3 really nice subtypes. So we have subtype 1, where the first thing to seem to change is the vulnerability index, followed by ventricular volume changes and NFL levels, and then the amyloid and tau is a much later stage. What's interesting is this subtype really is kind of picking up the cognitively normal phenotype. So it's mostly made up of true controls in preclinical Alzheimer's disease, okay? And they have low AD biomarkers. And 70% have no evidence of AD in their brain. Our subtype 2 was p-tau showing the first change, followed by amyloid, and then some volumetric changes in the brain. And so this is really giving us sort of an at-risk phenotype. So these are mostly made up of people who have MCI and preclinical Alzheimer's disease, and they have a medium level of AD biomarkers. And our third subtype, ventricular volume changes first, followed by p-tau, and then amyloid and vulnerability. And this group really is looking at a low amyloid phenotype. So it's some true controls and MCI that are probably not due to AD. Interestingly, there's no preclinical individuals in this group. And so they have low amyloid and atrophy markers. So we can use these phenotypes now to help understand disease. And as we test them longitudinally, we can follow that hypothesis that there may be multiple ways to getting cognitive impairment. So in the last 5 minutes, how do we apply this in real life? So first I want to show you sort of in a cartoon way. You have 4 individuals. They're all friends, they hang out together, they all play games, but they're all a little different, right? So this gentleman's overweight, likes fried foods, has high blood pressure, but doesn't have any memory complaints. This person's very fit, exercises, play games, not on any medicines, no memory complaints. This individual, very not physically active, does play games, not very adherent to their medical problems, has mild memory loss. And this gentleman does a little bit of everything and has some memory concerns. So you give them a test. They all scored the same on the test. They all scored 36 on the number symbol coding test, which is a borderline performance. So then what do? Are they all normal? Are they all impaired? How do you figure this out? Well, we collect additional variables. So now we can look at them and say, well, this individual has high vulnerability, but he also has high resilience. This woman has high resilience and low vulnerability. This woman has low resilience and high vulnerability. And this person has low vulnerability and low resilience. So now knowing that, we can apply our brain health platform, and we can see that these 4 people now are very different in terms of their risk. So this woman is at the highest risk for developing Alzheimer's disease. This woman's at the lowest risk for developing it. And we can now do something to try to help them. So let's take an actual case. So this is an individual, a 77-year-old Hispanic male, non-Hispanic male, 24 years of education, has a vascular path, hypertension, coronary heart disease, cabbage times 5, hypercholesterolemia, smoker. He has subjective complaints. He had no objective findings. So we did his biomarkers. He's at ApoE4, He has lots of amyloid in his brain. He has mild elevations in tau. He has mild elevations in NFL and GFAP. He has 1 microhemorrhage. So this would define someone who's then preclinical. We can see on our brain health platform that this is his performance. He has high resilience, but sort of a high vulnerability. He does have good cognitive performance. So he's in the normal range, but his risk score puts him in the intermediate range for progression. So we created sort of a personalized prevention plan for him. So we identified a bunch of things that we could address, and we came up with a plan for each of these things, looking at his resilience factors, his risk, vascular risk, and sort of proxy markers. And so we came up with this personalized prevention plan using integrative approach. And how did he do? Well, a year later, he actually became a little bit more physically frail, but he followed all the things we told him to do. He increased his physical activity, his cognitive activity, his mindfulness, so his resilience index increased. His vulnerability didn't get any greater. And we could look at the change in his cognitive performance, and he basically did better on almost all the cognitive tests a year later. Okay. And when we see this in our projects, we try to look at this and we're trying to measure adherence to our plan. And so if you follow our plan, what we found a year later, your cognitive performance increases. If you don't follow the plan, your cognitive performance sort of declines, and there's a differential effect. So for control individuals, if you don't follow our plan, your cognition stays basically the same. But if you follow our plan, you actually do a little better on your cognitive test. You start to gain cognitive abilities. For our MCI group, if you don't follow our plan, you decline. If you follow our plan, you show a little increase, and so you see separation of the groups. We can see there's a little bit of a difference in response by sex. Men have a greater response if they're adherent than women do. And we can see that the reason for that is because the people who are following are gaining in resilience that we can measure objectively. But what's really cool, if you're adherent and you're gaining resilience, you accumulate tau at a much slower rate. So we think there's some biology behind this as well. So now we can apply this in our clinical practice, right? So these are people that we see in the clinic. They're not in a research project. So they're not on a research schedule. They just come in when they come in for their clinic. So we just put it based on clinic visits. But there are people in the clinic who have no dementia, people who have MCI, people who have mild dementia, and you can see sort of differential responses. But the people who have no dementia, who are following this advice, they're pretty stable. Same thing with the MCIs for the most part, but the people with dementia continue to decline. But besides cognition, we can do lots of other things. So we can see, for the most part, improvement in everybody's depression scores. For people who have elevated homocysteine, again, applying our integrative nutrition and medicine approaches, we basically can eliminate homocysteine as a risk factor. And when we look at their renal stroke risk score, we have basically 2 groups. People start out with a low risk, they stay at a low risk. People start out with a high risk, we tend to decrease their risk. And we can look at predictors of response. So older age, male sex, lower education, and greater baseline impairment. So precision medicine approaches are really changing the way we think about and treat brain disorders. By studying vulnerability and resilience, we can help to begin to explain the why of why some people get disease, progress faster than others, and have lesser responses to medications. And they're really overall strong markers of brain health. By using our blood-based biomarkers, we can enrich our sample and provide easy, accessible evidence of at-risk people. We combine our deep phenotyping with omic and biomarker approaches, all our neurobehavioral markers and machine learning. So we continue to refine our characterization and hypothesis testing. Our goal is to define a resilience factor that may provide a druggable target in the near future. This can also allow pharma then to show that their drug slows, stops, or reverses cognitive change. But we found so far that resilient individuals appear to show less cognitive decline, have less cortical atrophy, and seem to accumulate p-tau slower. And we are now applying these principles in clinical practice. So I want to thank you for your attention. I left about 8 minutes or so for questions. I'm happy to field anything. Thank you so much.
Thank you very much for this really enlightening talk. It was very, very interesting. I have asked people to put their questions in the text box or to raise their hands, and I can read the questions if you would like. So the first question is, the idea that green space is correlated to higher resilience is fascinating. Is there more data on this?
Yes, there's a lot of data on this. So again, Dr. Besser, who's in our group, has a lot of data looking at this. You can get geospatial data going back into the late 1970s and early 1980s. And so we can track changes in green space, in heat indexes, and other sort of geographical things. And so if you have higher green space, you have a bigger brain, better cognitive performance, less white matter disease. And you can actually look at like redlining of neighborhoods. And you can see that those neighborhoods don't have as much green space. And it's really quite fascinating. There's an increasing volume about these structural determinants of health.
So were the SESs controlled for in the green space literature? Do you happen to remember?
We can control for that. So we have 2 measures. So in our project, we use both the area deprivation index, which is based on a zip code level, zip code and address level neighborhoods, so we can see how much resources that neighborhood has. And then we use a modified form of the Holland's Head index of social status, which is old, but actually works with a little bit of modification. So we use that. So we have 2 measures. We have a personal measure of SES, and we have a address level of SES.
Great. So another question, how much of an impact would brain injuries, sports accidents, et cetera, have on cognitive decline in Alzheimer's disease?
So brain injury is a risk factor for dementia. It didn't fit into our vulnerability model. It didn't add anything to our vulnerability model, which is very heavily vascular risk factor weighted. But it is a known risk factor for developing later cognitive impairment, both a major head injury with a loss of consciousness as well as repetitive minor head injuries. That major head injury with loss of consciousness is actually more associated with later Alzheimer's disease, where the repetitive head injuries is more associated with chronic traumatic encephalopathy.
Thank you. So is there any data to show how IQ scores factor into brain health, and how does IQ correlate with risk of Alzheimer's disease?
Yeah. So we collect verbal IQ on everybody. And so IQ is a very crystallized feature. And so, most people take their IQ tests around the 4th grade. They call it lots of different things because they don't call it an IQ test, but it basically is an IQ test. And it's very crystallized. So if you take your IQ test at age 85, it's going to be almost identical to what it was when you were 10 years old. And it's so crystallized that as long as your cognitively impaired people can read and speak clearly, their performance on an IQ test probably is a really good measure of their pre-morbid abilities. So IQ doesn't change all that much. There's some evidence, obviously, that higher educational attainment, higher occupational attainment may be protective risk factors. IQ doesn't necessarily correlate with any of those things because people can have high IQs and no educational opportunities. So it's not a strong predictor by itself of a risk of Alzheimer's disease, but it gives you some idea of where someone's highest level of of intellectual capacity was over the course of their whole life. So it's a very valuable thing to base things on. So if you're looking at two sets of neuropsych tests. One person has a very high IQ, one person has a very low IQ. Depending on where those scores are, if the scores are a little bit lower than the norm, but the person has a low IQ, they might be performing quite well. Whereas someone who's scoring a little bit above the norm, who has a very high IQ, might represent likely impairment and decline. So the IQ is useful for sort of setting what the benchmark is for someone's probable cognitive performance. And then you could look at and see how they're doing on their cognitive tests now.
Oh, thank you. So there is one more question about, oh, no, there's some more questions that just popped up, but there's one about cholesterol, optimum cholesterol levels in relation to cognitive function.
Right. So I wouldn't say there's necessarily an optimal one, but we try to look at total HDL, LDL, and we also look at all the little ones like LP little a and other aspects of it, so we can get a sense of what's the risk of plaque and plaque breakage and inflammatory responses to plaque. So we try to so what we try to do is we try to manage people without statins if we can, and then we use statins if we need to, and try to get total cholesterol and LDL down while raising HDL. But I don't know that there's a magic level that we try for. People who are ApoE4 carriers tend to have lesser responses to statins, and so that may suggest that alternative therapies would be a better option than the traditional kind of first-line statin.
Well, your talk is so fascinating, and all of these different things that we can do to influence and prevent future cognitive decline. It's really very exciting. Here's another question. How much of an impact does a history of long COVID have with brain fog and development of dementia?
Well, those are ongoing questions, right? So the data up until recently seemed to be pretty clear that the COVID virus was not neurotrophic, that it didn't directly affect neurons. What it did was affect small blood vessels, and so this was a microvascular / inflammatory response that was probably responsible for the brain fog. More recently now, they're questioning whether that's true or not, and there seems to be, at least in older adults who had COVID, they're at a higher risk for developing, cognitive disorders. So I think the jury's still out about that. But I spoke on panels like post-pandemic, and the neuropathologists were pretty adamant that there was no evidence of direct COVID effects on neurons. But I think the pragmatic data is that sure looks like there's some effect. So whether it's an indirect effect or it's a direct effect that we haven't been able to really measure, I don't think anybody knows yet.
So that'll be really interesting to follow in the coming years. So thank you very much for your really, really interesting, profoundly interesting talk. Very exciting because of the not just utilizing drugs after, it's a person's already entered into Alzheimer's disease. I think it's really important. So yeah, we are recording this, or is it okay if we put it on our site, Dr. Galvin?
Yeah, that's fine.
A recording. Oh, okay, wonderful. Because that I think it's a lot of people are going to be interested in seeing it. So thank you. We are very grateful.
Okay, well, thank you. Everybody have a great day. Okay.
Thank you. All righty.
Bye.